My name is Dr. Jessica Spat-Lemus, and I'm a neuropsychologist working with Dr. Stieg and colleagues. I wanted to thank Dr. Stieg for inviting me to conduct this virtual brain seminar. It's really my pleasure to be here with you today to speak to you briefly about stroke aftercare. I wanted to give you a taste really of just some of the work that we do here. Dr. Stieg's department really offers a very comprehensive and holistic model of service for our patients. So cognitive problems are very common after a stroke. It has been reported that 50% or more of stroke survivors actually experience some form of cognitive issues 6 months following a stroke, which can have a really big negative impact on a person's overall quality of life, including familial and interpersonal relationships. It can also be associated with emotional changes such as depression and anxiety symptoms. And the pattern of post-stroke cognitive impairment suggests that cognitive deficits can arise depending on what part of the brain is affected by the stroke. So a lot of times we look at our injuries and we're comparing them between diffuse and focal. When we talk about diffuse injury, we're talking about an injury that has affected large portions of the brain versus focal, where it's a little bit more specific in terms of a very particular part of the brain. I'm presenting here two very common types of stroke: an ischemic stroke that happens when blood flow through the artery that supplies oxygen, rich blood to the brain, becomes blocked. And that can cause focal or global cognitive impairments or deficits depending on the location of the stroke. And then we also have the hemorrhagic stroke, and that happens when an artery in the brain leaks blood or it ruptures. And usually deficits with that type of stroke are a little bit more global, affecting larger portions of the brain. And so different parts of your brains control different things. And this infographic is really just showing you a basic and broad overview of different lobes of the brain and what each of them can do. As you can see here, specific functions that we're able to carry out are really attributed to specific areas of the brain. So for example, the frontal lobe, which is located behind where you would take your temperature on your forehead, is responsible for things like problem solving or planning, organization, behavioral control, personality, and attention, among other things, other functions. The temporal lobe, for example, located just above your ears, is responsible for functions such as language and verbal memory. And so obviously, depending on where a stroke happens, that part of the brain and that function can be negatively impacted. And so as a basic overview, as a neuropsychologist, we have a unique perspective and really in terms of the study of brain behavior relationships, which really allows us to identify cognitive deficits or weaknesses, more specifically helping us with diagnosing brain disorders that could be secondary to neurological disorders such as stroke. And while cognition and behavior and emotion are interdependent, today we're going to be focusing on the cognitive and emotional pieces briefly. And when I talk about cognition, I'm talking about the process of really acquiring knowledge, understanding through thought, through experiences, and through senses. In neuropsychology, as I had said before, we kind of break down cognitive functions into different domains. And so that can include things like attention, memory and learning, language, executive functioning, visual spatial skills. And really a dysfunction in any cognitive domain can negatively impact another cognitive function. As you can see by the arrows, it's kind of insinuating that, attention underlies memory, memory underlies executive functioning can underlie language, and so forth. And there's a reciprocal relationship in some of these functions. They can be attributed to difficulties in a variety of daily tasks. And so the ways that we objectively measure what a patient reports feeling can be done through what we call a neuropsychological evaluation. And so we see this again in measures about what a patient is subjectively reporting, and then we can see it on our paper and pencil tests or computer tests. And while our tests provide really an objective measure of what's going on based on what a patient says, so scores, we compare it to performance, to a normative group. We also like to further understand the ways that these weaknesses are really negatively impacting or contributing to real-world difficulties. And so, for example, attention, language, memory, and learning executive functioning difficulties can have any one of these, can cause any one of these types of issues for patients post-stroke. So sometimes you might have trouble grocery shopping or editing documents, or taking notes in school if you're still in school, or navigating a route. All of these things are things that our patients will come and talk to us about, and we can see either objectively or through self-report measures. And so when I say cognitive remediation, what do I mean? And so cognitive remediation is really the primary goal. It's to ameliorate injury-related deficits, right? So we want to improve deficits in order to enhance daily functioning, to increase independence, and to really improve overall quality of life. And so more long-term goals in cognitive remediation include assisting our patients with becoming more aware, providing patients with the tools that they need in order to learn to compensate. So for example, something like a memory notebook to help with memory and recalling things in everyday life, and we're improving areas of weakness and deficits. And a lot of times we're assisting our patients to really internalize these strategies, right? So we want our patients to be able to use them and to have them in such a way that it's going to come natural, right? And so you want to use them in everyday life settings. So it's not just with us in session when we work one-on-one, but it's also that you want to be able to use it and generalize to everyday functioning to improve that. And so cognitive remediation and neuroplasticity, they go hand in hand. So very briefly, we think of the brain as a plastic organ. So that means that it has a capacity to change and it alter its structure and function. And we know that the brain has been shown to reorganize itself in the studies and in the literature in a change in response to cognitive exercise. So a lot of times enhanced recovery of neurocognitive function is associated with some type of organized stimulation, such as cognitive mediation or cognitive rehabilitation. And we have really learned about that, a lot about that, ever since when this all initiated cognitive mediation and its history in the 1920s. And so it's important to understand that cognitive mediation actually developed to some extent in the context of neurological surgery patients. It began during or after World War I in the 1920s. It began at schools to help wounded veterans. And during World War II, Alexander Luria, he developed and wrote about neurorehabilitation programs for soldiers in neurosurgical suites and units in Russia who had been experiencing cognitive issues. And the goal of it was for the soldiers to be able to resume functioning in society. And so after World War II in Europe and the US, patients that had brain injury underwent neurosurgical procedures would then go off and go to some form of brain injury rehabilitation units that were associated within neurosurgical departments. And so in the 50s and 60s and 70s, we also saw that there were advances in the concept of what we think of as neurorehabilitation based on a combination of cognitive revolution. There was a study of human cognition that was really coming around, and really we were learning theories about how we process and retain information. And there were a lot of medical advances in neurorehabilitation for stroke specifically. In the present day, neurosurgeons such as Dr. Stieg have been really implementing this idea of cognitive rehabilitation to really treat our patients from beginning to end and to really optimize overall quality of life. And so more of knowledge of the fact that neurorehabilitation can assist with management of a patient's presenting problems, we are seeing that improving them really following surgery in terms of late functional outcomes has been something that's very important to our department specifically. And so when to remediate? Spontaneous recovery after a neurologic event, just like stroke, is really fastest in the first 6 months. Cognitive remediation can really expedite recovery that happens naturally following a neurological event such as stroke. However, there needs to be some level of awareness and motivation to engage someone in treatment. So it's really better to start an intervention when the patient is aware of cognitive changes, or at least we can work through and really identify goals that need to be set. And often a neuropsychological evaluation can assist with such awareness. And so we also like to make sure, if possible, that physical or pain issues are somewhat resolved so that it doesn't interfere with a lot of the remediation if possible. And also we don't want to set up a situation where the individual might not do as well in treatment if there are other more immediate issues, just as what we were talking about before in terms of pain or physical functioning. So really underlying cognitive skills, especially things like attention, can improve with organized intervention even years after an injury. So when we talk about cognitive remediation, we're thinking of it in two aspects. And so the first is something called restorative. So really, how do we improve or restore an impaired cognitive functioning by using things like repetitive stimulation? So we use attention drills or memory strategies or metacognitive strategies and applying them on a consistent basis in daily life. We also think of another aspect of cognitive remediation as compensation. And so that's really using external items, such as implementing the use of a daily planner or a memory notebook in order to adapt the presence of the cognitive deficit. Treatment typically happens in two phases, which includes first, as I had mentioned previously, a neuropsychological assessment in order to identify or quantify underlying neurocognitive, behavioral, and emotional deficits that can be adversely impacting functioning, in addition to us identifying relative strengths that could actually be used to support an individual and can be utilized to assist us when creating our compensatory strategies. It really provides a guide to treatment so that we can not only tell us what the areas of deficits are, but also to show us that cognitive challenges in one area can impact another area. So we would be able to choose certain strategies based on this. One challenge, when we identify the challenges, we set the goals and the priorities which are identified, and together the patient and a person like me, the neuropsychologist or the treater, can really determine the tasks or the settings in which the challenges are really interfering with functioning, whether it's academic or occupational or vocational. And strategies are selected to address the issue, and activities are selected that will improve our patient's daily functioning within that domain. That second stage of treatment is really carrying out what we have together, the patient and myself, for example, have created the treatment strategies, and we teach how to begin to apply them. And so that's the way that we're realizing that patients are able to use them outside of the treatment, and then and if it's not working, we can come back to the drawing board and figuring out a way that could be most helpful for that patient. And so cognitive remediation is really goal-oriented. Goals can go from very general to very specific, but as treaters, we're really focusing, again, on how it generalizes to your everyday life. So, we know that a lot of our patients at baseline, prior to experiencing a stroke, were really engaging in work or academic functioning, and really had an abrupt break almost in an activity due to this diagnosis, due to the treatment. And so that's one of the things that we want to go back to, and really developing goals based on sometimes, most of the time actually, a return to function or work or school, even if it's in a modified fashion. And so another thing that cognitive remediation is very collaborative. So patients participate outside of the session. Both they're recognizing some cognitive errors, and they're usually utilizing cognitive strategies to remediate on an ongoing basis outside of the session. So we're going back, we're developing things as a team. We use possibly, a patient's own strategies that specifically work for them. We're encouraging this type of thinking and their use of those strategies outside of the sessions. And so we know that a lot of times as patients, they have, or you have had a prior way of compensating or processing information that really can be highlighted and used to an advantage in the cognitive remediation treatment. And so another way that it's collaborative is a lot of times we have intermittent family participation in the treatment, or home health aide participation in the treatment, depending on the severity of the stroke and the cognitive deficits or challenges. And that can be really useful in working with patients so that we're generalizing these strategies outside of the session and having another person being able to help our patient really use them. And lastly, as I said prior, we want to make sure that it's very generalizable. We want to make sure that our patients are not only able to perform well and learn the strategies in session, but of course, what we want them to do is being able to use it in their everyday lives, being able to use it when working, when in school settings, so that we know that then the treatment is working, because that's the ultimate goal. And so if I were to go through all of the examples of our cognitive domains and our cognitive remediation strategies, we would be here a very long time. And so what I wanted to do is just really take a brief example, just a snapshot of some of the domains that we have treated or we can treat that are affected adversely in stroke, and just run through some of the strategies that we have, just so you can get a sample or a taste of what we do in session. And so one of the domains that we work on, and that is actually really negatively impacted a lot of times in our stroke patients, our patients with stroke, is executive functioning. And executive functioning is really what we think of as a set of processes that assist the brain to organize and act on information to control behavior. I think of it as the CEO of the brain. When you think of a CEO, you think about someone who's able to plan, to organize, to problem solve, to sequence, to be flexible in their thinking, and really to be able to self-monitor both themselves and their employees. And so that's the way that executive functioning works in the brain. And so in terms of some of the things I have listed here, these are subdomains of executive functioning. So different things like problem solving again, or sequencing and planning. And on the right are actually what could happen when that goes wrong. So for example, with problem solving, it might really be difficult for a patient to figure out ways to approach a problem and to find multiple solutions to a problem. When one doesn't work, can they go to the next solution? Or for example, in terms of sequencing and planning and organizing, they might lose track of steps. They might be a lot more disorganized when they're trying to figure out what they have to do, or they might have difficulties planning an event when before they were able to. And then also types of executive functioning include some types of emotional regulation, such as frustration tolerance. So a lot of times we find that patients after stroke might actually feel like they're not able to deal with things as they used to. They might have a little bit more of a shorter fuse. They might feel like they're a little bit more impatient. And so again, these are just types of executive function. And so what we do is we take, depending on what the patient presents with, we're taking some of these or each of these, and we're working on them individually. And so a lot of times our patients who have executive dysfunction might talk about their impairments in this way. So they might say, I'm not so good at making decisions, or I'm having difficulty starting things, or I make a lot of mistakes. I cannot figure out a way to solve the problem. And based on what they bring to the session and what we see also quantitatively on the neuropsych assessment, we start to work on some of these. So for example, one of the things that I've had patients have trouble with is a strategy for problem solving, right? So a lot of times they have patients have had difficulties integrating multiple pieces of information, which is really the nature of any given problem one might come across. And so a lot of times on top of the problem solving, we might be a little bit more impulsive, right? Let's say we're not thinking before we're doing something, and so we're not able to really anticipate the consequences of our behavior. And as a result of that, we're going to have difficulties being able to solve a problem when the first strategy doesn't go our way. And so a problem solving strategy, one can be taught, or a patient can be taught in any given problem, is something that's more systematic by going through a 4-step process. And so the first one is stopping and really identifying the problem. So what is it that I'm having trouble with? The second one is really thinking about alternatives and options. So we're really planning an optimal approach to solving this problem. And then we're executing the plan once we've selected one. And then we go ahead and review the outcome, okay? And so just so that you can get kind of a little bit of a picture about how that would look like with a patient, this is something that happened with one of the patients that we've treated here along, and my colleague as well, who has done this, who does cognitive remediation with patients. And so one of the things that you can see here is stopping and identify the problem. What was the problem for this patient? This patient needed to find a psychiatrist who took their insurance. And that was very difficult for them because it made them very overwhelmed to have to think about things that wasn't working or wasn't in their immediate reach. And so they really needed to find a psychiatrist who took their insurance and understood cognitive dysfunction, which sometimes could be difficult. And so what happened? They were asked to list alternatives and options. At this stage, you're not really judging whether or not it's feasible or not. At this stage, you're really just listing all possible solutions to the given problem that you've identified. And so it's later that we go back and we select what we think would be better and what we think would work in order to really execute the plan. So for this patient, in terms of not being able to find a psychiatrist that takes their insurance, here were the generated options. They can ask their current healthcare provider for suggestions. They can call their insurance company. They can go back to a psychiatrist from before neurological injury, go to a local psychiatric clinic, call psychiatrists in the area and ask if they take their insurance. And so the patient then went and selected one or two of these options that would be feasible, what would make the most sense depending on the situation. And then they listed planned steps at how to go about fulfilling that. So they decided to call their insurance company to ask for providers. And what they did was they brought that list to their current psychologist. They decided then to outline the symptoms to present to the psychiatrist, and then they called to make an appointment. And so a lot of times this really helps a patient understand more the stepwise, the steps to solving an issue that maybe before was very automatic. And while it seems simplistic, it's something that can be used for any problem that you could possibly think of when you have to think about different solutions or different options. Something else that we go through when we talk with patients, and a lot of times our patients will talk about memory issues, which sometimes we like to make sure to distinguish from attention issues, which can be confounded or thought of as a memory issue when in fact it's more attentional. When we think about encoding in memory and consolidation, it's really the initial stage of memory. And it's where some analysis performed on the material to be remembered. It's where we organize and categorize the material. And then we have storage of the memory, which refers to transfer of that memory to more permanent retention. And a lot of times, if a patient has damage to the area of the brain, in the temporal lobe area, they can display difficulties with storage of this information. And retrieval also refers to searching for or activating an existing memory. So deficits in memory retrieval can really be impacted by things like frontal lobe pathology, or what I said before in terms of attention executive functioning, which sometimes has downstream effects on memory in general. And so it's important to distinguish that. And so a lot of times our patients that have memory issues will say that they are forgetting what they're supposed to do throughout the day. They're forgetting important things that they should have done. Maybe they don't recall conversations they recently had. They're forgetting where they're putting things. And so as a result, we work on certain strategies that can be very helpful. So again, just to really give a very quick summary of what possible problems are and what the possible strategies are that we work on, you can see here on the chart that I've provided. So like difficulties recalling what happened or things that were told. A lot of times a patient can carry a memory notebook, or they can use a voice recorder to take notes. If our patients have had difficulties recalling appointment times, names or phone numbers, a lot of times we help them use a daily planner to schedule appointments or refer to a daily. If they may misplace items frequently, you can identify one place to really put all important items, which sometimes is something that is not done when we analyze the problem and the goal. And also there might be difficulties rapidly accessing newly learned information. And so a lot of times we teach our patients these associations that I'm going to show you in the next slide very briefly. And so a lot of times what we do is we're practicing these strategies, and what we want, again, as I had mentioned in the beginning, is to help a patient really internalize these. You want to make them as automatic, and what we do is we try to make them as automatic as possible, so that a patient is really not only learning to practice this in such a way that then all of a sudden it becomes something that they're using in their everyday life, that it becomes something that just is. And so when we look at here, remediation really is teaching a person to impose a strategy onto the information they want or intend to remember, okay? So information in long-term storage is organized a lot of times on the basis of meaning and associations, and we use that in order to really provide our patients with these types of strategies. A lot of times the associations are really anchored to the item to be remembered, to an existing memory or an idea that is in some way related. And so a lot of times, because it can be utilized as a cue to really organize and recall this new information. So, I'm sure individuals can think of some mnemonics that they've used to remember, for example, the items of operation, PEMDAS when you were younger, if you had used it or if you're using it now. And so we kind of go through some of these strategies, and we make sure that a patient is able to use them again more automatic after repeated use. So some of these strategies can include a visual imagery, right? So you're using a visual image or retrieval cue for verbal information. It could be more elaborative verbally. So you're using either a semantic related association or acoustically related information, or sometimes you can use both visual and verbal, where there's a story method, where you're creating a story of something that you really want to remember. You're also generating a visual image of it, and you're incorporating that information that you need to be remembered. One of the things that I want to talk upon briefly is something that we know that patients who have experienced a stroke have reported difficulties, again, in aspects of behavior and mood. A lot of times it could be that patients have become more agitated. They might have a shorter fuse. There might be aggression in some ways, or not able to sleep as well as they used to. And we know that depression and anxiety, again, are very common following a stroke. And so a lot of times these are some of the symptoms that we see that our patients present with. And sometimes it's not necessarily something that they know they can define it as depression or anxiety, but rather, these separate symptoms that we know can fall under a more of a psychological disorder. And so, psychological aspects of cognitive remediation do include understanding that a person is mourning their former sense of self and the perception of cognitive dysfunction. So, a person has changed. There are emotional reactions to what it is that they're experiencing. A lot of times we know that anxiety and depression can impede cognitive efficiency and concentration. So nearly 45%, for example, of stroke patients are experiencing, this along with fatigue, which obviously compounds things like depression, anxiety, and vice versa. And so a lot of times the way that a person also presents premorbidly, so before the stroke or the injury, can also determine the way that they cope. And so a lot of times we talk about this in cognitive remediation. And then we also discuss the discrepancy between perceived self and actual abilities, and really how the role might change in the family, right? And how we can help to mediate that in remediation with the help of some of these exercises. And so, when we think about treating the psychological aspects of a neurological event, we want to make sure that the individual, we really want them to be engaged in their own improvement process. And throughout treatment, in and out of session, they're going to be encouraged to rely on themselves. Of course, we're here as a support mechanism, but really we are reinforcing an individual to recognize their own strengths, building on that, their intact level of functioning, and really incorporating those opportunities of success in treatment. And we know because success breeds success. So you want to use natural abilities and strengths. You want to really adapt and reinforce, which is what we do with our patients. And then we try to reconcile the need to use compensatory strategies with a functional sense of self. And so finally, just as a summary, cognitive, mood, and behavioral changes can be expected following a stroke. And the good news is, though, we can really learn to compensate, improve our abilities following a stroke. And cognitively stimulating activities or cognitive remediation has been shown in the literature to really improve or limit the impact of cognitive decline that we see following a stroke. And more importantly, we know that the downstream effects on improving cognitive issues can also improve mood and can really help our patients to feel as though they're able to once again function in their everyday lives. Thank you.
Okay, Dr. Spat-Lemus, we will take audience questions. If you look in the chat box.
Okay, let me go back. Let me go to the chat box.
If you open your chat window.
Yes, let me do that. Okay. Yes, okay, so I have the chat window open. And so it says an attendee asked about how long improvement can continue. And so, okay, perfect. And so yes, so we have seen in our patients that even years following a stroke, depending on what it is that the cognitive deficits or the weaknesses are, even if it's several years past, we have seen that improvement can continue depending on what cognitive domains are affected. And so a lot of times, as I said, yes, we want to remediate as soon as possible, generally 6 months following. But for some of our patients, even several years following the stroke, we do see that improvement does continue we do see gains basically in our patients. And I think, like everything, what we want to do is we want to make sure to work individually with our patients in order to set them up for success. So a lot of times what we can do is take individual difficulties and we work on them specifically, even if this year's post-stroke, right? Because a lot of times these problems have now generalized. So you might have had an attentional issue starting 6 months following your injury, and a lot of times we never learned a compensatory strategy. And so what happens is even afterwards, several years later, we can learn how to do that. And so we find that our patients do really assist. And so a lot of times a caregiver can also really help a patient to really internalize these new strategies. And so as a result of that, we can incorporate them into session, as I had said before, which could be a little bit different, right, than what maybe was applied to before when the patient initially had a stroke. And so that's why a lot of times we see that there are long-term improvements, and the research does show that as well. Oh, thank you very much. I see some of the comments here. And yes, so I'm going back to some questions. So this does apply also to some non-stroke injuries. So for concussion, yes, we also see that cognitive remediation can assist in other areas like concussion. And so a lot of times, especially for concussion, we work on things like attention, executive functioning, which a lot of times has a negative impact on memory. And so that's one of the things that we do work on. And so yes, we have patients that, especially here in neurological surgery, we have patients that come and present with different neurological disorders, but yes, that's also one of them. Let's start just going down. Yes, I am open for new patients, as are my colleagues. Dr. Heidi Bender and Dr. Zach Zimmerman. And so a lot of times in terms of the training, so we are trained as neuropsychologists. So yes, we know the brain-behavior relationships. And so one of the things that we do is we also have additional training in rehabilitation, so cognitive rehabilitation or cognitive remediation. And so one of the things that we do is we also, not only do we assess neuropsychologically, but we also are able to follow a patient and really look to see how that treatment is really impacting or improving some of those functions. And so, yes, we can leave a number for the appointment. So are we applying or integrating a combination of technology as part of the tool set? Yes, so we do also have computerized cognitive remediation software and services that we also offer for our patients. And so I think that it's really important, at least what we see in the literature, is that there's an integration of both this computerized or more technologically advanced tools and also in-person training. Because a lot of times the softwares that are available or the programs that are available, there's a piece where a patient is really working on their own, but also has some support from the neuropsychologist. However, it's great to really supplement with in-person training because we can kind of go through and work one-on-one on what is working, what is not, and kind of coming back and really rethinking and like really thinking about it and what is it that's going to work. So there is some research to suggest that neurofeedback can really assist with cognitive rehabilitation or cognitive remediation. It's something that's utilized in certain disorders much better than in others. It's not necessarily something, for example, that we're using primarily here, because it's just been shown that more the cognitive rehabilitation, the evidence-based recommendations and putting them into practice are actually much better in this way, where we're working one-on-one with our patients with these paper and pencil treatments and things like that. Strategies. So some strategies for patients who do not have insight into their deficits. And so a lot of times it's actually working with patients to think about really here we're doing a lot more more awareness training. So we start out, it might not right away go into a lot of these strategies that we normally would with other patients, right? So instead of working right away with some associations for memory or attention processing training for attention, we would actually start by just making the patient aware of what is going on in terms of bringing in a caretaker as well, and we're looking to really help them to understand what could possibly be impacted first. So it's more about becoming aware. So the beginning of training is really more metacognitive, right? So how do we make you a little bit more aware of that? How do we use what we've seen in the data, or what patients or what your family is saying, or what's happening at work, or what's happening in other aspects of your life, and how are we improving that? And so a lot of times it just becomes first really making them aware of what it is that's possibly can be affected and the ways that they're seeing that. And so what we do is more stepwise, and we start really at the more basic level, and then we build upon that, so that at one point, even if they're not necessarily aware from it, what they do is they become just more aware of looking for the things that we would normally think would be something that's affected.
Okay, so if there's no more questions, I think we'll wrap up. Thank you so much, Dr. Spat-Lemus. You got a lot of good feedback, and we'll see you on the next virtual brain.
Yes, thank you so much. Have a good day.